The next presenter is Dr. Mudit. He'll be presenting on a new technique for Rhegmatogenous RD, and the discussant will be Dr. Jignesh.
All right, so first of all, good afternoon and thanks to ARC for giving us a chance to present our work on using FIbrin glue in retinal detachments. Now, we all know that whenever we do a past plan of vitrectomy, and vitrectomy for detachment is now becoming more and more common. In fact, in one of the practice and trend surveys, we found more than 70% of surgeons prefer a vitrectomy in cases of inferior RDs also with a single tear. Now the problem is that whenever you do a vitrectomy, we end up using silicone oil or gas tamponade in all of these cases, and they come with their own set of problems. You need to give a post-operative positioning to all of your patients for at least 2 weeks. There is always a risk of glaucoma, corneal changes and cataract. There is a delayed visual recovery till the time you do a second surgery to either remove oil or till the time your gas bubble gets absorbed. You need to do a repeat surgery to remove the oil. And if you have put gas inside that, then there's a restriction in air travel. And therefore we decided to see if we can obviate the problems that silicone oil or gas produces by using FIbrin glue as a tamponade. Now what does a tamponade mean? Tamponade essentially are agents which provide surface tension across breaks in order to prevent fluid from flowing back into the retina till the effect of the laser becomes permanent. And it takes 48 to 72 hours for the laser effect to come. So you essentially need a tamponade agent only for 48 to 72 hours over here. And FIbrin glue, the agent that we thought of using, has already been used extensively in ophthalmology in ocular surface procedures, in scleral fixation of intraocular lenses, but also in retina, in optic disc pit associated detachments, and even in macular holes. Fortunately, we also have animal studies which show that it is not toxic to the RP. So we have an agent which has been used in retina and is not toxic to the retina at all. And therefore, we decided to explore its role in detachments. So the technique is pretty simple in the terms of whatever you were doing earlier. Do a vitrectomy, settle the retina, do a laser. But now after doing a laser, instead of putting oil or gas, you put a drop of FIbrin glue to cover the break. No post-operative positioning needs to be given to any of our patients. So this is one of our patients, and here if you can see over here, we did a surgery for this patient. The initial steps are simple. You do a complete vitrectomy, remove all of the vitreous. Subsequently, after removing the vitreous, you do a fluid air exchange through your retinotomy. After you have done a fluid air exchange, you do a laser. But after doing a laser, that's when the next step comes. Now in an air-filled globe over here, after completing of laser, you put 1 drop of FIbrin over the break, and after waiting for 2 minutes, a coagulum gets formed. Now this coagulum can be just easily lifted, and after you lift it, you can just place it to cover the break, and that's the end of the surgery. You don't need to put oil, you don't need to put gas. And this is how the patient is the next post-operative day with the retina attached, visual acuity improving to 20/100. At 1 week, the entire FIbrin glue goes away, it gets absorbed spontaneously, and you have an attached retina, and the patient did not have to sleep in a prone position. You don't have to put oil, you don't have to put gas. This is one more of a patient with an RD. This is how the patient is on the first post-operative day with absolutely clear media and fluid inside the and an attached retina, and the coagulum goes away in 2 weeks. So we have now done it in more than 50 cases, and our outcome measures were anatomical attachment and improvement in visual acuity. And at just 1 week, see, the entire visual acuity improves to 20/80. This is something which we could never ever achieve with conventional tamponades. So these are some of our cases. Inferior detachment, this is how the patient is at 1 week over here. Another patient with vasculitis and detachment, and this is how again the patient is now at 2 weeks. Another patient with an inferior RD 2200 vision, first post-op day at 1 week and at 2 weeks. We have now even started exploring it in some of our TRD cases. So this was a patient of SLE with a break over here inferiorly. And this is how the patient on the first post-operative day, under fluid eye, attached retina, coagulum covering the break. 1 week, the coagulum gets absorbed, leaving behind an attached retina. So FIbrin glue now allows us basically an opportunity of an absolute early post-operative recovery in an RD patient, visual acuity improving within 1 week, no positioning, no gas or oil tamponade. Thank you so much.
Fantastic. It's going to be a game changer because you're going to stop using silicone oil and all the complications which are coming up will be stopped. So it's very nice. Only what is the follow-up period for such cases that you have, and what is the vision? Is it stable or is it going down or is it better?
So we started doing this surgery for the first time in 2019-20. We now have patients who have a follow-up of more than 2.5 to 3 years also, and their visual acuity is stable and maintained. So the visual acuity that comes at 1 month finally gets maintained and stays that way.
And what is the site where you have put the FIbrin glue? What is the status there? Does it go into fibrosis or
nothing at all,
is there any pucker which is appearing because of the glue, because of the contraction?
So
Anything
there is
that you have
no pucker
noticed?
at all. because this is a protein. It gets absorbed spontaneously by itself within a span of 8 to 10 days. So there is no pucker that has occurred over there. We have been able to do serial OCTs over that area, and all that shows is a flat retinopathy with surrounding laser marks, but no membrane, no pucker. In
Fair.
fact, theoretically, it will actually even reduce the chances of PVR, because how does PVR occur? It occurs because of RP which gets proliferated. Now you have
Absolutely.
covered the break, you are even preventing RP from coming out. So theoretically, you are even reducing the chances of PVR occurrence in these cases.
Fantastic innovation. Thank you very much.
Thank you. Yes. So the size does matter. Thank you so much for that question. So this is a technique which is used for early simple RDs with breaks limited to 1 or 2 quadrants. For extremely large breaks, which is breaks larger than 3 disc diameters, we do not recommend it. And the reason is that if you put it in a very large break of more than 3 diameters, the problem is that the glue can go subretinally and it will not then serve the purpose.
What about the clock cars? Have you covered 360 degrees all the one thing, only in the dependent and superior position? Which positions have you got the maximum
So we have
results?
done it for inferior RDs, we have done it for superior RDs. We have now done it in total for 57 cases. Of them, 29 were inferior retinal detachment. It works extremely well in inferior RDs, also in superior temporal nasal. Once you have put a drop of fibrin and the coagulum is formed after 3 minutes, it doesn't go away anywhere. It stays that way.
Fine. Thank you, sir.
Thank you so much.
We go on to our